developed for RTTDC. I doubt that many of you will have to enter this, but who knows what's going to happen in the future. So anyway, through the online course management system, you can put in new course requests, faculty information, a link to the online pre-course survey questions. The disclosure forms are there, can be downloaded, printed, etc. Receipts and disbursements form, and summary of the evaluations by the participants. So we're trying to make more and more things electronic so that we can access them wherever we're at, so that we can actually have an online system that stays up to date, and we know how the courses are being administered and how what the evaluations show. So this has been dropped. There used to be a $100 course fee, which does not seem like a whole lot, but still, facilities complained about it. The course text is sold to course organizers for $50 each. They need to be ordered 6 weeks in advance. The reason is sometimes they lose the requests. We put the request in for Hettinger in early February. I approved the course. Sometime in March, nobody had received anything. We called and they said they had no record of the course ever being approved or submitted. So there's a lot of stuff that goes on in the national office. So I actually forwarded them the communication and the approval for the first course. In the meantime, we'd already approved a second course, to be held the same day. So anyway, so I don't know if there's extra manuals out there. I doubt it. We probably just got one shipment. So the course materials also include a DVD, one CD. The DVD holds all the course slides. CDs are for some of the other materials. I actually have mine on a thumb drive is what I have. So that's a little less bulky to carry around. So, we need to teach the facilities and the providers at these facilities. And, during the break we had a discussion on one of the big barriers is getting them past the point where they think that they need to completely evaluate every patient and have a definitive diagnosis prior to initiating transfer. And that is absolutely 100% erroneous. All you need to know usually is they really look sick and they got a bunch of injuries, and there's no way that I'm going to be able to fix them here. Now, the big thing about this course is for once, okay, and there's an increasing trend for the college to really realize that we have two separate populations in the United States. We have the folks in the big cities, okay? They're different, okay? What they see is different. And how they are able to treat people is different, because when you have 5 level 1 trauma centers within a 30-mile radius, boy, everybody's going to be able to get to a pretty good place in a short period of time. On the other hand, when you've already gotten a foot of snow and you're 150 miles from the closest level 2 trauma center, things are different and people die. Okay, so we got to do the best we can with what capabilities we have. And a lot of times it's these folks in the rural hospitals, they really need to have some of these life-saving skill interventions and knowing who I need to get out and how soon do I need to get them out. And the answer is real soon. So I'll see if I can pull up this lumberjack video here. Patient scenarios incorporated into the primary assessment sections. Instead of just talking about the airway or talking about breathing, we actually have a patient-based scenario so that the providers can relate to more of a real-life situation. And then we have all these worksheets, which most people have given me the feedback. It makes them think a little bit more about their own facilities, capabilities, and how they're going to be able to manage it. And it kind of makes a situation where in the future, they're going to be thinking more and reflecting more on, you know, I don't really need to be keeping this person. So we expanded on peds and special, you know, considerations, and that's the elderly, pregnant, et cetera. Performance improvement, policies have been changed a little bit. The college will now provide CMEs, not a local institution. RTTDC at facs.org or call Chicago.
Pretty rapid sound.
And the poor guy's looking around thinking, holy crap. Yeah. Yeah, that's called Strider. It's impending.
Christy? Yeah? Why don't you send somebody else to me? Because I might have to too, Kim. I'm going to need you.
Take all the things off the stretchers, all the sheets.
This is a small hospital, like a critical access type facility.
And there's crap.
Yes. So watch the time here, right? 3 minutes. So they're dabbing blood and, you know, looking at the stick.
Should we wait for that chopper to get here?
I don't know. It's something he wants to give intravenously. Who knows? So the saturations are still okay. So I guess nothing to worry about. See, it's So that really deteriorates when you finally stop breathing.
Obviously, he's perfusing his brain pretty good. So.
You want to just start getting your shoes off?
So they're virtually doing nothing at this point, right? Just walking around and talking. Right. And they have no plan. Right, right. Yeah, yeah. Well, or the morgue wagon, whichever arrives first. Right. That way he can oxygenate transcutaneously better. So I don't know if they're gloved and gowned sterilely because they're waiting to do a trach or a crike, you know, and that might be, nobody really shares that. That could be a thought. The first attempt, though, might be for oral endotracheal intubation because sometimes it's surprisingly easy.
Which one? He's trying to light in front of your office over there between your and mine.
Why don't we just go?
Yeah.
If we have to, we have several options. We can attempt intubating during flight, and we can do tricon.
Yeah, you may have to do a tracheotomy on it.
Yeah.
You know, if that thing, no, and it's sucking out. If that thing comes out, it's probably a fraud. So
Yeah. Well,
so let's not disturb him anymore.
yeah, let's just
Just hold still.
try to fight. Is he
Yeah.
going to be able to lay down real quick while we're loading in? Because if not, what we're going to do is just
Well, we could say I'm back with you in there.
Yeah. If not, we better take him out like this and lift him up and load him in a
Sure
stretcher.
enough, that's good.
Going in. What do you think, Jim? Huh? You might have to do it all the way down. Yeah. See, what I thought is if we lifted him up into the helicopter, it might be easier to lay him down.
Kind of lay you down,
Yeah.
yeah. You can lift him up and slide him in that way from that stand area.
We can't do that.
Yeah, they probably called in advance, is what I assume. So that was, at least they did think about that.
Try to lift him out of the stretcher. Yeah. Just take him out on the stretcher. I'll take this back out and load it.
You've got a 14-inch elbow on one side and 16-inch the other.
Okay, that's it. Wait, we have pressure.
So much for the 5 minutes for the primary and secondary assessment and making decisions, because they're at 8 minutes now. 9 minutes and we still don't have an airway. I don't know exactly. We might be able to see some of the markings on the helicopter. I think it's out west someplace. Further out west than us. No, not in our state. Remember, there's very few trees in North Dakota. They don't have any major lumbering operations. Right. It could be Oregon.
Okay, everybody, here we go. Get that suction running.
Got it.
Okay, Christy. Just take it around. There we go. Okay, the next thing's going.
So when you show this to the course participants, you should invite them to write down all the errors that are made in sequential order. You need to give them several sheets of paper, but, huh?
They just keep bumping it.
Yeah, well, they probably don't. I mean, you know, they might have a chainsaw in the hospital, but they probably didn't ask for it. But
No, but I mean, just large bulky dressing and
yeah, I agree. But of course, if you got to trach them, you don't want the large bulky dressing. And you have to remember, this is a group here which appears to be, you know, paralyzed by lack of preparation and knowing what to do. It probably doesn't make it any dirtier, okay, frankly, because remember, it is a piece of wood from, you know, the forest, okay, you know, which has Clostridia and fungus and all sorts of great stuff. And actually, saliva, you know, is bacteriostatic, okay. Animal saliva is bactericidal, it's even better, okay, but nevertheless, yeah, it doesn't look good. But there's nothing about this video that looks good. Everything looks horrible. Does he live? I don't remember. I'm not sure. We want it to be a surprise. We don't want to spoil it for you. The first versions, you could actually read stuff and see faces. Subsequently, probably because of audience objections to the stupidity, they've probably blacked them out. It's a life flight from somewhere. Yes, they are not bagging him. Right. Remember, the number one priority is get them out of your ER. Yes. And there's, yeah.
Okay, we're good. We got my wire yard. We're still alive. That's a cook.
Yeah, it's an old school video, so it's not real high quality, but we really don't want to see a repeat of this, so I don't think they're out hunting for another incident like this. They didn't know what they didn't know. Yep. Montana. That's my guess, because there's mountains, and Bannock is an old town in Montana. Or was it Babcock? Bannock?
Everybody's Googling it.
Right. Huh? Presumably yes, but I assume. But not for anything that they did there. Okay? It's just that he may have been lucky. He survived on his own. It was survival of the fittest and the luckiest. And frequently that is how trauma was treated. You know, I mean, if you go back to even, let me think, it would be the early 70s. Most of the transport vehicles were owned by funeral homes. Yeah. And, yep, and the degree of training that people got who were attending to the patients was basically nothing. Okay, I was an ambulance attendant, okay, which is that was pre-EMS days when I was going to college. Okay, I'd do it on the weekends. Now, I had worked in a hospital, I had worked in an operating room and an ER, okay, so my qualifications were better than a lot of the other folks. One of the guys that drove frequently was actually worked in the radiology department as a file clerk, and that was what you got. Okay, but I hadn't gone to medical school yet. I mean, I had some basic skills, but they were real basic. I'd seen chest tubes put in, but not that many, because it was at a real tiny little facility, you know, where we were based. But it was, you know, the guy that owned the ambulance service used to work at a funeral home, and then he bought a few of the used, you know, hearses, converted them, okay, and that was the state of the art at that time. So this is an extension. They're obviously doing better than, you know, then, because they have helicopter transport. It's late 80s, and yet they're really not organized. I mean, they probably knew how to do a trach, okay? But what they didn't do is they didn't get their crap together when the patient hit the door, because you always got an airway issue from the time they hit the door, and they waited about 9 to 10 minutes before they did anything. And in the meantime, they dabbed blood. They used a Yankauer to suction the wound, the mouth, the nose, blah, 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 instead of really doing anything. They didn't have priorities, okay? Now, are they bad people? No, they just aren't prepared, you know? And that's why these courses allow you to help these people organize their interventions and their thoughts, okay? Because you see something, you see a stick hanging out of somebody's neck, and you say, oh my God, look at this thing. And then you futz around with it for 10 minutes instead of saying, hey, this guy's gonna have an airway issue. He may have trouble breathing as well. just because of the airway issue. And by the way, is he bleeding? You know, is he going to get a hematoma? And that's why he's going to occlude his airway. Is he going to arrest because of blood loss? So, I mean, you got to be thinking of all those things. This guy looked like he was probably fairly healthy. He was a lumberjack, okay? They're usually healthy, maybe hungover, but at least healthy. You know, the airway intervention. And then, you know, I don't know how well he was breathing spontaneously after presumably, you know, a drug-assisted intubation. So all of that time where they just had the bag in the vicinity probably did not ventilate him adequately. So, and he may already have been acidotic from hypoperfusion, not breathing well, all of the expenditure of energy while he was maybe working to breathe. So he remained amazingly calm, though. I mean, you know, so I mean, really a brave guy. The video is unique in that it is absolutely horrible care in the way it was initially provided. And that's why it's still being utilized for shock value. Because it really hammers home A, B, C. You know, don't be stupid. Don't focus on the stick. Focus on the trachea and the airway. So, and that's why it has been included, even though it's, what, 23 years old, 24 years old now, is because, you know, it's going to be hard to find anybody who's going to volunteer to let you film them doing this that way. And hopefully nobody's doing it that way. And yet, after having said that, there probably are places that might occasionally do it that way, depending upon who's providing care at that time, okay? So that's your goal, is to prevent this from happening. And there's not a lot of lumbering, obviously, in North Dakota, or if there was, it was some years ago and they took all the trees. But, yeah, but nevertheless, the same type of stuff happens here. It happens on the oil rigs. It happens in the fields. I mean, we see people impaled by other objects. Rebar is pretty common. You know, you'll see people impaled by rebar. That's even a little harder to cut off in the ED because you need a, you know, a metallic cutoff saw. And actually one of my buddies has a video of that, you know, cutting it off in the operating room after they've put somebody to sleep. And he had gotten impaled from the supraclavicular fossa, and it came out his contralateral buttock. So there's a lot of really impressive things with penetrating trauma, but it all comes down to the same thing, A, B, C, D, and E. And think, and don't just focus on one thing. There's an ATLS video from years ago, again, with somebody with a minor open fracture, I mean, if they can be minor, who has a, you know, a respiratory arrest while they're futzing with the open fracture. So, and that's another video that everybody is just dying when they're watching it, just saying, no, do this, no. You know, because it's just, I mean, it's so contrary to the way everybody's been trained. But you have to remember, if you're working in a clinic, and that's your main stuff, treating hypertension, STDs, etc., and then you're thrown in the emergency department and you got somebody with a stick hanging out of their trachea, boy, it's a new thing. And you don't even think that way. I mean, it's real easy for you guys because you have been trained that way and you repeat it and, you know, understand the value of establishing an airway. But a lot of these folks, you know, it might be kind of a little bit of a new concept for them to think in that fashion. And they really struggle with some of these courses, by the way. So, questions? Yes?
So, can we use the semis and the simulation when we do the World Trump Team Development course?
Yes.
After having this presentation with you, so if our facility is doing a World Trump Team Development course with the course coordinator and the appropriate instructors, can the semi go out so that we can do the scenarios with the simulator?
No, we got to run that through ND Star and the state to get approval. But originally that was part of the plan, and that's why you're hearing this.
But you're not assuming that we will be key instructors for World Trauma Team Development course, or not necessarily?
You know, it's going to depend upon what the local trauma center wants to do, because it gets coordinated through them. Okay, and since many of you do work at the, you know, level 2 trauma centers, you may very well be part of the crew that is going to be, you know, teaching. Okay. So, and I think there's going to be more of a need and more courses that need to be given than maybe everybody, you know, that the 5 instructors from each level 2 are going to be able to facilitate. That's what, you know, our impression was, given the number of rural facilities we have. Because basically, with the exception of about 7 places in the state, maybe 6, every place is a rural facility. So, you know, and I don't know how much time everybody's going to have if they can go out, you know, besides all their other activities, you know, if I can talk Dr. Kane, Dr. Viney into, you know, going out every week to do a course. They might want to, but, you know, their own facility might have something to say about it, like you can't be gone that much.
Well, even if you run them in tandem.
Huh?
You know, even if you did it in tandem, because
Right.
you do your real time, and then in the evening, maybe run some simulations. You know what I mean?
It's possible.
And Dr. Sledger,
Yes.
the group knows that the trauma protocols are being incorporated in the trauma scenarios that you will be using on the trucks. So
Right.
we are working in collaboration to develop that process.
You know, we will be incorporating that training into SIMND. We're just obviously not going to start that right away with all the other training, because if we tried to do it all at once, we'd fall flat in the face. So we're gonna gradually ramp up, but it will be part of it too, with Dr. Smith's help.
Tell you, Rome was not built in a day. It took about a week. So it'll take a while. So I don't know what the rest of their day looks like, because.
Tim had a few things.
Okay.